Hi, I'm Dr. A. Ganesh and this presentation is about enteric fever, otherwise called as the typhoid fever, caused by Salmonella, typhi and paratyphi. Coming to the introduction about the bacteria per se, it's a gram-negative bacillus which is motile by peritrichous flagella, except Galnerum pullorum which is non-motile. It is a non-sporing and facultative anaerobic bacilli. Paratyphi and typhi, the infections are restricted only to humans, whereas certain groups which are called as the NTS, that is non-typhoidal salmonellosis, can affect all living beings. The serotyping of this bacteria is done mainly on the flagellar H antigen and somatic O antigen. So this is a gram-negative bacillus which is motile and non-sporing. Typhi and paratyphi are restricted to humans alone. Pathogenesis, this is transmitted mainly by contaminated food and water. The infecting dose ranges from 200 to 10 lakh colony forming units. Once it enters the gastrointestinal tract, it traverses the intestinal epithelium and are engulfed by the macrophages and resides within the macrophages without getting destroyed. Then it gets disseminated throughout the body and colonizes the reticuloendothelial tissues like liver, spleen, lymph nodes and bone marrow. It multiplies there and as a result the cytokines are produced which are responsible for the signs and symptoms of typhoid fever. So it just enters the gastrointestinal tract, from there it seeds the reticuloendothelial tissues. Coming to the non-typhoidal salmonellosis, NTS. The main difference between NTS and typhoidal salmonellosis are typhoidal infects only humans, whereas it can infect all. And in the infiltrations are seen in both large and small bowel mucosa in case of NTS, and the infiltrates will be predominantly polymorphonuclear cells. Whereas in case of typhi and paratyphi, it is monocytes and the infiltrates are restricted to the small bowel mucosa. This is one of the difference between NTS and typhoidal salmonellosis. Following are the predisposing factors for typhoidal infections. That is, anything which is going to decrease the stomach acidity and anything which is going to impair the intestinal integrity can predispose to typhoidal illness, typhoid fever. That is, less than 1 year, patients who are on acid suppressants and patients who have achlorhydria, because HCl is not produced, hence these patients are at risk for developing typhoidal infections. And inflammatory bowel disease, cytotoxic drugs, antibiotics that destroys the microbiota in the gastrointestinal tract, and gastrointestinal surgeries. These are the predisposing factors for salmonellosis. Enteric fever. The reason why this is called as enteric fever is the signs and symptoms are mostly related to the abdomen, and also site of infection also is in the abdomen. Hence this is called as enteric fever. This is also called as typhoid fever. Typhus, which means clouding of consciousness. This fever, when diagnosed early, the patient mostly will be having muttering delirium, that is coma vigil. Hence there will be a clouding of consciousness. Hence this fever was called as typhoid, that is typhus like illness. It is called enteric fever because of the site of infections. The clinical features ranges from fever and abdominal pain is seen only 1/3 of the patients. Incubation period ranges from 5 to 21 days, and paratyphi predominantly causes gastrointestinal symptoms. The other symptoms that can be seen are headache, chills, cough, anorexia, abdominal pain, nausea, vomiting and diarrhea. Hence predominantly the symptoms are related to gastrointestinal tract, and hence it is called as enteric fever. On physical findings include a coated tongue, splenomegaly, abdominal tenderness, relative bradycardia, rose spots in case of fair-skinned individuals, and hepatosplenomegaly. The rose spots appear at the end of the first week and disappear within 2 to 5 weeks. The importance of these rose spots are, these are predominantly seen over the chest and trunk, and salmonella can be cultured from these rose spots. The complications of salmonella, that is typhoid fever, in the form of gastrointestinal bleed and hemorrhage usually occurs in the 3rd to 4th week, and this bleed and hemorrhage can be drastic and can lead to mortality also. The neurological symptoms of typhoid fever are meningitis, Guillain-Barré syndrome, and muttering delirium, as we said here earlier, and coma vigil. These are the rare complications. It can induce disseminated intravascular coagulation, hemophagocytic syndromes, pancreatitis, hepatic and splenic abscess, pancarditis, endocarditis, pericarditis, myocarditis, architis, hepatitis, glomerulonephritis. It can involve almost all the organs if untreated. Pyelonephritis, HUS, pneumonia, arthritis, osteomyelitis, endophthalmitis, parotitis. Chronic infection, if patients are untreated and left, they can shed the bacteria in urine and stool for years. And this salmonella has a predisposition to colonize the gallbladder, where they can form biofilms on the gallstones and survive there. And this is most frequent in patients with anatomical abnormality of the gallbladder and its tracts. This infection can predispose to gallbladder cancer also in the long run. Diagnosis: only blood culture is specific. Preferably culture the buffy coat, because the buffy coat contains the cellular elements which contains the bacteria. Bone marrow culture can be done, and the importance of this bone marrow is this bone marrow culture is unaffected even after antibiotic therapy. And there's one test called the string test, in which the patient is asked to swallow a string, and the duodenal aspirate is taken and is cultured. Stool culture can be done only in the 3rd week. Coming to the treatment, the main treatment are 3rd generation cephalosporins and fluoroquinolones, but because of the resistance of the fluoroquinolones, they are not considered as the first line drug. So empirical treatment, it is either ceftriaxone or azithromycin. Ceftriaxone 2 gram per day, that is 1 gram IV BD for 10 to 14 days. For fully susceptible individuals, you can, if it is not resistant to fluoroquinolone, you can try ciprofloxacin and other drugs like chloramphenicol and Septran. If the patient is multi-drug resistant, again the drug of choice is ceftriaxone 2 gram per day, azithromycin 1 gram per day for 5 days. And if it is quinolone resistant, then also you can choose ceftriaxone. So ceftriaxone comes in most of the area. Ceftriaxone at 2 gram per day for IV for 10 to 14 days. Thank you.